He is telling me how Kenya is moving towards having a registered society, and that's very exciting. I think around the world there's now 50 societies of lifestyle medicine, and anyway, it was a great pleasure spending time with Isaac and being able to share some time with him. And he's asked me to speak with you today, and it's a great pleasure to do so. Apologies in advance for my lack of Swahili. I have none. So I will give you this presentation in English. I'm just going to share my screen with you now. Isaac, is that coming through clearly as a slide?
Yeah, it is.
Thank you. Will you keep an eye on time? And please, anybody, if you have questions, don't hesitate to ask. This has been recorded, and I will leave the slides also with Isaac to share with you if there's anything here. And because I'm not sure exactly your knowledge on this idea, I'm going to go back to basics, but please don't hesitate to ask any questions. I'm going to talk with you today about shared medical appointments. There's lots of different names by which it is known: group visits, medical yarn-ups. There's a whole lot of words that describe more or less the same sort of process. So I'm hoping today that we'll just do a bit of a background on it. I'll see where they fit in. We'll have a look at a concept called program shared medical appointments and what some of the strengths and weaknesses of this are. In my country, in Australia, we often acknowledge the traditional owners of this country, the Aboriginal people of Australia. And I often use this slide to work when I'm working, especially with my non-Aboriginal colleagues, to show them this slide, which is a fish trap that is dated at 60,000 years of age. And Australia has only been settled by Europeans for 250 years. So it puts in perspective how long the traditional owners were here for. I'm not so sure what the custom is for Kenya, if there's something similar, but I acknowledge your ancestors and your current leaders. A little bit about me. So my home is in a place called Mullumbimby, and it's an Aboriginal word for a meeting place. And you can see here that Australia and the world, I'm on this east coast of what's called New South Wales, and I live in a very lovely place called Mullumbimby, where there's mountains and sea and ocean, and it's very clean, and it's a very ideal place to live. People want to live here. It's very peaceful, and people are very kind, and it's a very lovely place to raise your children. It's also a place where people think a lot, and it was out of this area that lifestyle medicine grew in Australia. As Isaac said, since 2008, we were thinking about it well before that. A lot of friends of mine who were doctors and colleagues and a few nurses and other academics. Myself, my background is as a medical sociologist and a lecturer, academic and researcher in health. And we decided we no longer wanted to do health the same way, that health that was led by illness wasn't working for us. We wanted health to be led by wellness and try to prevent illness and to manage chronic disease with lifestyle rather than with treating the illness itself when it was all too late. So we formed the Lifestyle Medicine Australasian Society of Lifestyle Medicine in 2008. We now have about 1,000 members in Australia, and as I said before, now they're around the world. The Americans started about the same time as us, 2008, and around the world there's now, we think, 50 countries with organizations that are nearly ready to be lifestyle medicine societies, which is extraordinary in just 15 years for so many countries to go this way. But it must be right, because the clinicians who think this way are starting to grow in number and in voice, and it's clearly a way to think about health. In Australia, we think of it like this. It's the application of environmental, behavioural, medical and motivational principles in the management of lifestyle-related health problems in the clinical setting. Essentially, it is using lifestyle as medicine. That's probably the simplest way to put it. And like most of the countries around the world, we all have something similar, which is we focus on these 6 evidence-based lifestyle medicine pillars. And every country has its own version of this. And in Australia, we have this one, but we also have another one, which has a lot more pillars, if you like. But for consistency around the world, this is the 6 pillars that we look at: nutrition, exercise, substance abuse, stress management, sleep, and healthy relationships. And those relationships are with other people and communities, but also the environment, the natural environment as well. And this is the basis of our lifestyle medicine, and it's evidence-based. This is the important part. A lot of people, when you use the word lifestyle medicine, I don't know how it is in Kenya, but in Australia, those words, for some people, make it think of women's magazines and relaxation magazines rather than hard science. And so we are very strict on making sure everything is as evidence-based as possible. So there's some of my colleagues and team who started. I was fortunately one of the founders back in 2008, and Gary Egger, whose name you might have heard of, Andrew Binns also was part of our starting, and our most recent president, Sam Manger. I haven't got a photo of our new president, whom you went from. Just to sort of put some perspective into what's happening in Australia, if you don't, I'm not surprised if you don't hear much about us in Kenya, but we are 25 million people, and you can see from this slide, these dots represent where the population density is. We have lots of people living in cities around the coast, and hardly anybody living in the centre. It's open for everybody in the centre there. There's hardly any people living there. And it's hard. It's a hard place to live. That's why. And this poses problems for us, as you can imagine, probably very similar to Kenya. In the remote villages of Kenya, I imagine you have similar problems in trying to manage resources to give for people's health. Around the world, so our issues are like we have 1 in 2 people in Australia have a chronic disease. Probably 80% of all visits to a general practitioner is for a chronic disease now. And that's changed dramatically in the last 20 years, where the dominant number was for infectious disease or injury, and now it's all about the chronic disease. I'm assuming there's some similarities here. And cardiovascular disease, cancer, and diabetes seem to be the big ticket items. Many of them can be prevented. And what we know is also that's a tiny fraction of our health budget is spent on prevention and the management of chronic disease or lifestyle. Less than 1.5% in Australia, which is it's a ludicrous amount of money considering how important it is. If you can prevent a disease, you don't have to manage it, right? And so in Australia, the main issues are the way we eat. 95% of our issues are about the way we eat food, and not enough fruit or vegetables, too much takeaway and fast foods and high calorie foods, etc. We are inactive. We've become from Australia, you probably have an image of us being out in the surf and out in the bush all the time, but no, most of us are stuck behind our desks and we don't move very much at all. And as a result, about 2/3 of our country is overweight or obese. We have about a 30% obesity rate, and all those problems that lead from there. I tell you this as a bit of background so you can picture this rest of this talk, if this relates or not to Kenya, the Kenyan situation. One of our issues, and this is where I come into talking about shared medical appointments, is that our conventional one-on-one medical consultation, where a patient will see a GP, was very good once for managing infectious disease, or if you have gut problems or other illnesses, but it's not very good for managing chronic disease or preventing disease, because they're short periods of time and the GP often doesn't have enough time to explain the information that's required or develop the knowledge and skills. And so the patients walk away. We know the patients walk away from this scenario losing 80% of the information that was delivered to this GP by the time they get home. 80% of it is forgotten. And most patients have forgotten to ask the most important questions that they came to us, because there's a pressure going on in this time frame, and there's a bit of a power relationship between the powerful doctor and the not so powerful patient. And this is multiplied when it comes to marginalised groups like our Aboriginal people in Australia and other people from other countries. This is even worse. So we have been working in Australia. We know that most clinicians understand about lifestyle medicine. We know that most clinicians do know about good diets and exercise and sleep and stress, all those pillars they know about. But we haven't had a way to communicate this effectively to our patients and work with our patients on these issues because of this type of consultation process, because it's too short and there's too many issues and too many barriers to getting good information about prevention and lifestyle management in here. So we have been working in Australia for maybe 10 years now on trying to work with this idea of shared medical appointments. And as I said, you'll see this as many different names. In the UK, they like to call it group consultations. And in the United States, they call it group visits. And our Aboriginal people call it medical yarn-ups. So there's lots of different names for it. But essentially, they are individual medical consultation. That means everyone gets your attention one-on-one, carried out sequentially with a number of patients in the same room, led by a skilled facilitator with other patients with similar concerns listening and contributing. So rather than seeing one patient in 10 minutes, maybe we see 8 to 10 patients or 15 patients over 90 minutes. And there's a small team of a facilitator and in this case, the doctor. And the facilitator will manage the room and the 15 patients. And the doctor will still do what the doctor does, which is consult with the patients and do what they do. You can also then add in other people. It does not necessarily, if your resources don't allow it, but if they're there, you might also then use allied health or practice nurses. You might even be lucky to have someone who can help take notes. But each time we create a shared medical appointment, they're all individually customized to your needs and what your resources are and what your patient's needs are. So this is easy to say, but it's much better when you actually see a photo of one and you can get the image if you haven't seen this before. So this room is in a very remote area in Australia called Burke, which is probably 600, 800 kilometres from Sydney. And in this rural area, there are not many doctors, and it's very hard for patients to find time to see a doctor because of there's just not enough of them. So in this situation, this particular doctor was worried that his patients have diabetes, and for years they've had diabetes, and he's never had enough time to talk with them properly about their diabetes. And no matter what the programs are that they've been shown before, it hasn't worked. So he's asked us in this example to show, to demonstrate a shared medical appointment. And there's a bit of a technique with the shared medical appointment, and ASLA, my society, does train a lot of clinicians in how to do this. So what I'm telling you today is just like an orientation to it. But if you want training specifically in it, we can do this as well. And there's some techniques and ideas that we have, which obviously for Kenya might be very different, but somewhere to start. But you can see they're sitting in a circle. This is very important for the way in which we communicate in this situation. The facilitator is, in this case, there's my big nose you can see poking out there. And what would happen would be this doctor would have recruited these patients, says, come on, George, come on, Grace. I'm not getting through to you on this diabetes thing. Why don't you come to my shared medical appointment on a certain day? And they will turn up and they will have some idea what's going on, but maybe not fully. And I will welcome them before the doctor comes. I will be the facilitator. I'll tell them about the rules of engagement, how everyone's going to get a consultation. We're going to share our information. I sometimes use this whiteboard to put up their people's names so everyone can know their names. And sometimes I will put up their questions. What have you come to see the doctor about today? And this first person might have said, oh, I have sore feet. And the other person says, yeah, I got sore feet too. And someone says, my medications aren't working very well. And so I put this up, the questions up, so the patients themselves go, oh, yeah, I forgot to ask that question last time. I'll ask it. This person's asking it for me. At some point, I ask the doctor to come in, maybe 10, 15 minutes after everyone's settled down and the rules of engagement are explained. And then I introduce the doctor to, this is part of the group management. I select the very first patient to be someone who's going to work. This man in the corner, he's very shy. He doesn't want to talk too much. This man over here, he's very angry. I don't want him to talk. And this woman, yeah, she's not very confident either. This man, however, this man here, he's very confident. I've spoken to him. He wants to know more about his sore feet. And that's something a few other people have a problem with. So I say to the doctor, doctor, would you please talk to Brian here? He has a problem with his sore feet. And away we go. So their consultation begins. And for maybe 3, 4, 5, 10 minutes, it doesn't matter how long, this man and the doctor talk about the consultation they would have had they been one-on-one in the room. But now everyone gets to listen. He goes, yes, that's my problem. Or, I have a solution to that. I used to have that problem and this is what I did. And so with me as the facilitator, I can allow people to say these things and bring in their ideas about what their issues are. And as we go around the room, everybody, by the end of the shared medical appointment, everybody's had an opportunity to have their one-on-one consultation with their doctor. And by the end of it, however, everybody has heard a lot more than they would have in 10 minutes. They've heard other people's answers. They've heard the doctor explain things in more detail. They've had people ask questions that they had forgotten to ask. They commonly say, the most common thing they say is, I don't feel alone anymore. I just thought I was the only person with this problem. And now look at this. I've got a whole lot of colleagues and friends here that I can see that have the same problem. So there's a lot of confidence and great expectation that comes out of this group. During COVID time, we realized that we could do this same process. We could do this online as telehealth. And this has been extraordinarily powerful because of all that remoteness you see in Australia. Our doctors can now go on to telehealth. They don't rely on people having to come in. They can go out. And we still have a really good connection with our patients. This is the facilitator. This is the doctor. I was just there as an observer and helping. And these are the patients. These are all patients with diabetes. And when COVID came, they were very frightened about their diabetes and COVID and what it meant for them. So this was a shared medical appointment where this doctor called called this group of people together, and managed by the facilitator, everyone got to ask him their questions about their diabetes and COVID. And it was a terrific session. He did this many times and it was very, very successful. And now it's a very powerful tool that is used widely in Australia now. This is an example of one that's under a house. These are Aboriginal men who often like to meet in unusual places. They don't like to go to hospitals and they don't like to go to doctors' GP clinics. The clinics for them are sites of oppression and racism where bad things happened when they're in history. So they don't like to go there very much. But in this situation, they come. They come and they see their doctors because it's safe. This is a safe place for them. And they'll see this doctor now. And they'll have their questions answered just as if they'd been one-on-one in the clinic, which they would go to. But now they feel safe amongst the other men and they talk freely and they help each other. And it's a very powerful tool for the Aboriginal men. This is one, not a very clear photo, but this is of general community, mothers with unsettled babies that are having trouble. So the mothers bring their babies, 6 or 8 at a time, come in with their babies, and they sit around and they also have a one-on-one consultation with the pediatrician and a lactation consultant and a midwife, and they have a series. This one's done over a series of 4 weeks, and these mothers learn how to settle their babies down and fix their problems this way. And this is another Aboriginal scene with Aboriginal women who were overweight, that were trying to lose weight, and they couldn't do it one-on-one in a doctor's surgery was not working for them. So they tried shared medical appointments. They call it medical yana. And in this corner is the doctor, and on the other corner is the facilitator, and the women are in the middle, and they're talking about their weight and they're having their consultation. And in this case, they were able to bring in a program of exercise. As not only had they have the consultation, but when that was finished, they would just immediately go into an exercise program. And these women lost enormous amounts of weight. We published a paper on this in 2019, and it was a very powerful example of how a shared medical appointment can work. I'd like to show you a video, if I may, of what one looks like, so you can envisage it. I need to stop sharing my screen for a moment, and then I need to share it again. And I'm sorry, I realise Isaac did ask me to describe a number of these things because some of you are driving to work. I haven't done a very good job of that, I'm sorry. Anyway, let's have a look at this movie. This movie, there we go. About a medical appointment. If you're driving to work, what you're going to be seeing is a doctor from Australia who is doing this for the very first time, and there's about a 10-minute video of him doing a shared medical appointment. And I'll leave this with you also because it's a very good, if you haven't seen it before, and when you see it, you go, oh, and it's not that hard, right? It's not a hard process conceptually, and this shows it quite well. This video is about a group of older patients with diabetes who for a very long time were very illiterate about their diabetes, didn't know much about it. And even though he'd been their doctor, and some of them were admitting that 40 years later, they've had diabetes for 40 years and still didn't understand it. But after this one session, as a group session, they got it. This is a 10-minute video. I will not show you all of it. I'll just show you some elements of it, just so you can get a sense of it. And you see the role of the facilitator and how they help manage the group and make sure the doctor stays on time and stays on track. And it's also important that if this is a shared medical appointment and we've decided that it's going to be about diabetes, if someone comes in and says, oh, I've got a breast lump, what shall I do about that? We have to sort of say, well, I'm sorry, but we don't have the resources or capacity right now to deal with this because it's out of what we've planned. But this is important. We'll make an appointment for you straight away. As soon as we're finished here, we're going to make an appointment and follow that up. But we need to sort of stay on track as far as diabetes goes. Anyway, let me show you just a few minutes of this video.
Appointments is a perfect place for people to learn from each other, as well as actually cut down on time for people trying to get in to see their doctor. The educational part of it, I think, where other patients are learning from each other it's really interesting. I've never really seen it happen as well as it has. And the added benefit is if people can get to see their doctor more readily and perhaps more frequently when needed, then it sort of wins all round.
Hazel, do you have anything today that you'd like to see Dr. Jeffrey about?
Yes, well, every time I walk around the house, I go walking shopping, I get base of my spine, I get, quite sore.
Sugar's gone up.
Sugar's gone up a bit, has it? Okay. Well, maybe that's something we can talk about, because that would be something everyone experiences in the group probably, from time to time.
Well, one thing I should say is I got those ball foot things that you put underneath your
yes.
ball, and it's made a difference. It's stopped a lot of tingling, actually.
Great. So he
recommended a foot.
They call it a football, I think.
A football.
But to me, football's rugby.
No, from England says, man from England says that's not football.
So I'll just pause that for a minute. That was a little opening scene where the facilitators welcoming the patients in and settling them in and trying to understand, trying to get the juices flowing, if you like, about why they're there to see the doctor and feeling relaxed about being there. And me, as the facilitator in this case, was sort of carrying on that conversation. And whilst that's happening, I'm getting an idea of who's the good talkers and who's the bad talkers and who's going to have something in common and the likes. My colleague Gary was writing stuff on the board there. That was a bonus that we had in there to do that. Very shortly, when everyone sort of settled in, the GP, Dr. Jeffrey comes in, and then he begins his consultations with the patients. And you might also notice, you would think nobody else is interested in anybody else's illness, but have a look how keen they are. They're looking at each other, they're engaged. It's a lot of fun too. Like one of the things of shared medical appointments is there's a lot of fun. People joke and have a lot of laughter, and it changes the whole power dynamic and makes it a much more joyful experience for everybody. So this next couple of scenes is about the doctor coming in and taking over, starting to do their consultations.
I usually just do mine fasting blood sugar first thing in the morning, and I'm quite happy just with that. I know what I'm doing.
Yep.
I can see what I'm doing. But if I were to do it after a meal, how long after the meal do I do it?
The recommended time is about 2 hours. So I guess the thing about blood sugar levels is there are standard times when people are advised to do them, but the main thing is as long as it's consistent, so that if you were to take your blood sugar, within an hour after every meal, and that's when you did it, then you'd soon tell whether your body's able to respond to that sugar load. Or if you did your fasting blood sugars, it would tell you how your body is at keeping and maintaining, your level.
Which is probably a good segue into Reg, because his main issue this morning really is his sugar levels are up and down a bit at the moment.
Yeah. So
yes, I was up to 9, so I've got to try and get myself down again.
Yeah, I think I might have cheated and had a look at your notes when we were sort of getting ready for this morning. And did he write something about strawberry jam and stuff? Was that you?
Yeah.
You want to tell us about strawberry jam?
No, well,
That's nice.
I realised this, and I knew I probably shouldn't have this sort of thing because I've had diabetes for 40 years or more, and occasionally you get lackadaisy and you walk in a shop and you say, oh Jesus, I'd like to have a couple of those, and I've done a bit too much of that, and I've realised now I've got to get me hide myself from taking any of that sort of stuff,
The problem with diabetes, as you all know, that you get this small, tiny vessel disease and it can affect the nerves. And the tiny little nerves that supply your feet can just go crazy because they're not really getting, good blood supply. Just like you're not getting strawberry jam and sultanas anymore.
Yeah.
So maybe, Reg, can we get your shoes off again? So what about if you close your eyes, and tell me, can you feel me touching you there?
I'll stop sharing that bit of video, but I'll make that available to you to have a look at when you can. For those of you who couldn't see it, it was a group of 8 patients sitting around in a circle talking with the facilitator and the doctor. And the doctor in that last scene just got up and went over to the patient and took his shoes off and started showing people and demonstrating why diabetes can affect your feet and cause gangrene and feet problems. And it's a really good demonstration. And what happens is then, if you're seeing that that video, what you see is how interested everybody else is. They're all looking at that foot and they're going, oh yeah, that's exactly what's happening to my foot. You can see them sort of taking on that information as well. So it's very, very powerful. I'm just going to share my screen again and go back to Go back to the slides. Hopefully. Right. So there are many types of shared medical appointments, and as part of you taking them on, you've got to sort of plan what it is you want to achieve and what you want to do. There's ones we call homogenous, and these are the ones we do mostly in Australia. And that's what we gather people with similar diseases or similar problems so that they have something in common to begin with. So in this case, in that video, we gather people who have type 2 diabetes and whose literacy is very, very poor and need to learn more about it. We might also gather together people with chronic pain, or people with amputations, or people with cancer, or people with obesity. So we gather the group according to what our patients' needs are and how many patients we've got, and we put them in together, and that's called an homogenous group. And that's what we do a lot of, because it's a way of, it doesn't matter then what the patients come with. If they have diabetes but they want to talk about their sore feet or their medications or their cold or their infected toe, then that's all okay. But the common thing is their diabetes, so that when the GP is talking and the educators are talking about what's going on for them, there's crossover and learning there. There's another type called program medical yarn-ups, or sorry, shared medical appointments, which if I have some time left, I'll explain a few of those. But essentially, it's a series of shared medical appointments where you drop in a curriculum. So if you want people to lose weight, it might be a series of 6 shared medical appointments separated by a week, so 6 weeks worth of medical appointments. But they come together as a group and they learn how to eat better, how to move better so they can lose weight. And you might have a proper program in there on how to do that and start measuring them as they come in each week. Likewise, it might be a chronic pain program where you might have a psychologist come in as well and work with you, and over 5 or 6 weeks develop skills in managing chronic pain. If it's malnutrition or obesity, the same sort of thing. So we bring people together and we actually act with a program of information to help them. There's another type the Americans use a lot, which is called the DIGMA, the drop-in group, a medical appointment. We haven't used them much in Australia, but there's no reason they wouldn't work. But it's basically setting up a time in your practice, a regular scheduled time, where people can drop in with any problem. And they'll come in, 10 or 15 people will come together, sit around, and they'll have a shared medical appointment with you. And the problem could be anything from a cold to an infected foot to nothing to do with diabetes. Like, it could be very varied. They tell us this works very, very well, and no reason not to believe it. And these are some of the examples in the last few years that we've got practices using them with. Apart from just general medicine, these are some of the special programmed areas where they've got into menopause and asthma and bad sleep, etc., 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 diabetes care, obesity measurements. So they're really, as you read through the literature, there is very few conditions where this won't work. Great with mental health issues too, stress, anxiety, and depression. Again, I won't read through this entire slide. What's the slide that is up at the moment is about the evidence for shared medical appointments. And what we know is there's over 9,000 published articles in the last 10 years about shared medical appointments or group consultations. All of them, and I haven't read every 9,000, all 9,000, but all of them are showing how powerful they are in terms of improving the effectiveness and efficiencies in your practice, saving time for clinicians. They reduce waiting times and presentations in emergency centre because you're so effective within your practice. Less patients go to the hospital. They improve patient self-management and competency, so they become more skillful at managing their illnesses, like diabetes, for example. And the patients and the providers like it. They like it a lot. And the providers love it because you say it once to 10 people and not 10 times to one person, knowing that that person's not going to remember it. You say it once to 10 people and the chances are they're going to remember it because they're going to comment on it and they're going to reinforce it with each other, and they're going to feel supported in this group. So the amount of knowledge that is retained is a lot more. I haven't yet read one article that says this is a bad thing. Shared medical appointments are bad. Not one. And I haven't read 9,000 articles, but I've read many, many hundreds. Want to talk about program shared medical appointments because I find this in Australia is extremely effective. And for those of you who are just listening, there's different ways to deliver these programs, face-to-face or online, because our online technology in Australia is working quite well these days. And so you can transmit a lot of information, as we are doing right now on Zoom. And a lot of the programs can be done on Zoom as well for the patients. So they don't even have to come out of their houses, and it's quite effective. And we can not only deliver the shared medical appointment, but also a program of information, as I described before, maybe in obesity management, in cigarette smoking cessations, for example. And we can stream that information. So your facilitator and your educators don't have to be experts in weight loss or chronic pain or whatever the issue is. But as long as they can push the button and you can stream information through, they can facilitate conversations that might flow from this. And an example would be, this is one we have done with Aboriginal people about quitting smoking. And so not everywhere this is done is there an expert in smoking and how to quit smoking. So if we allow the facilitator to stream this and show it in their session, all they have to do is push the button and...
Hi, I'm Hayley. I'm from Waminda. I'm going to be talking you through the program structure.
I'm not sure if you can hear this.
We have 5 yarn sessions with an Aboriginal health worker as well as a medical doctor. Each session goes from 1 to...
I'm not sure if you can see this, but this is a narrated PowerPoint. And at the bottom is a person that the people that we're targeting will find appealing, another Aboriginal woman who's a leader in their community. And she's taking them through a session on, how to quit smoking. And so now the facilitator only has to sort of push the button, and Hayley talks to a narrated PowerPoint. And over 5 sessions, she delivers this program in a shared medical appointment. At the same time, the doctor's in the room, and not only are they having their one-on-one consultation with the doctor at some point, either before or after, but they're also getting this education. And they can bounce their questions off the doctor as well if the program raises things that the facilitator cannot respond to. And a good example of this is one we did with reversing diabetes, where we did a reversing of diabetes using lifestyle medicine with Aboriginal people. And we used a three-pronged protocol using a continuous glucose monitor, a change of diet, and medical yarn-ups at shared medical appointments. And these women got together on 7 occasions, and they talked about their diet, and they got educated in their diabetes in front of their doctor. The doctor did consultations as well. And over a period of 8 weeks, these 25 of these women were able to reduce their blood sugar levels to a point where 7 of them are actually no longer having diabetes. They had reversed their diabetes. And this has been an amazingly powerful program that we've been able to implement in this Aboriginal community. And for those of you who can't see the screen, I've just got some outcomes slide of four of the participants who reversed their diabetes that had been diabetics for years, have been overweight, have been taking insulin, and they no longer take insulin. They no longer take a single drug to manage their diabetes. And it's because of the way they've been able to use the shared medical appointment as a way of not only doing their medical consultation, but also getting their education. And because they're in a group, they feel supported, they don't feel silly, and they don't feel over empowered. Lots of other examples of that, which I'll leave on these slides for you to have a look at and read. I'm getting towards the end of what I need to say here, but the research continues to show really powerfully why patients like shared medical appointments. They say again and again, and there's hundreds and hundreds of papers that keep repeating the same outcome, that they get extra time with their doctor and it's much more relaxed. They have questions answered that they may not have thought to ask themselves. They get support and hear experiences of other people. That's probably the most important thing. Seeing the doctor and provider are more relaxed. They learn more about self-management, not only from the doctors, but from other patients. They get their doctor's full attention for a long period of time, and they get to see their healthcare team, not just the doctor in action, and that's a good thing. The doctors like it because they don't have to repeat things over and over and over again. They get assistance and work as a little team with their facilitator and anybody else that's in it. If they do this well in Australia, we're able to improve their time efficiency in practice 3 to 1. That is, by having 12 people in the room for 90 minutes, they're increasing their time efficiencies by a factor of 3. That is, they can only see in 90 minutes, they can probably only see 6 patients at the very most. But in 90 minutes, they can see 12 to 15 patients. So their efficiencies are improving. And it's very good for the practice. There are barriers, of course, and I'm making this sound very, very easy. And the process is very easy, but how you embed this into your practice, no, it's not so easy. You've got to take a lot of people along with you for this change, because it is a big change. One, you're going to need to bring the community along to suggest that working in a group is good. And patients only have to do it once. And my experience and our experience of doing this many, many times is that experiencing it once, this is the way they want to do health forever. They do not want to go back to one-on-one, except very private issues. But when it's managing chronic disease, this is how they want to do it. They want to do it with their group of friends, their community, and this is very, very powerful. They want to see their doctors for longer periods of time and get more information. So if you can get them into the first one, then you have them forever, because it's so much fun. Bringing your whole practice along, this is a very difficult thing for some places, because you'll have people who do not want to change. And if you have 1 or 2 people in the practice that don't want to do it, it's very difficult to do it. The costs in setting up, initially there could be some costs, and you might find that until you become efficient with it, it's costing you money to do it this way. But in the long run, it's going to make it very, very efficient and cost effective. There's always a question about confidentiality and privacy. What happens? All these people are listening to all these people's problems. And there's ways in which we can get around that by signing confidentiality agreements and just working with a group. But the reality is, once you're in this group and you as the GP have recruited these people to come, so you kind of know who they are, and you know their personalities, and you know if there's warring factions or there's troubles between family members or whatever. You don't ask them. You ask the people that you know are going to get on. And when they're in this group, they don't talk about stuff. They don't reveal information. What goes on in the group stays in the group. We've never had a problem in confidentiality in Australia. The Americans who would do 1 million, literally 1 million of these SMAs per year, have never had a lawsuit about privacy or confidentiality. So, it's pretty good once we get going. I'm going to stop sharing my screen now and ask you if there's any questions.
Perhaps, John, you could mention about there was initially talk of getting consent from each one of the people before they come.
Yes. So Isaac, thank you. It's a good question. The part of the process of setting this up is that you, as the doctor, when the doctors ask the patients to come, we get an 80% success rate. Yes, I'll come. If the nurses ask it, it's about 50%. If the office staff ask it, it's about 10%. So if the doctors are asking, during their one-on-one consultation with their patient who may be overweight, would you come to this shared medical appointment and we're going to talk about weight or how to be healthier with your weight? And so you'll get an 80% success rate. And in that process, the doctor can explain, this is what's going to happen. We need you to sign a confidentiality agreement. You not talk about this stuff outside. And yeah, you get them to sign a form, but more importantly, you just talk about it and they agree. And you've selected the right people to come. That helps.
Thank you. And for those that need the CPD points, there was a request put in the messages for you to put in your email address so you can be given the points. Sorry, that is a message from the KMA branch. Thank you. Yeah. Any other questions? Perhaps it would be fine to go. Yeah.
Yeah. This is Ogot.
Welcome, Dr.
Yeah. Hello, John. This is
Hello,
John.
Doctor. Yes.
That is another John.
Hey, Dr. John.
Yeah, thanks. This is a very unique concept. And I had a question for you, but also maybe Isaac. My background is in obstetrics gynecology. And in obstetrics, we have these shared clinics, the antenatal clinics, that at the moment we have, as clients come in for their review, mostly nurses-led, but also with clinicians, patients are pooled and they have this education program where maybe information is given on nutrition, on appointments, danger signs, as a group. How does this compare to the model we are discussing? That's the first question. And the second one is, does this substitute one-on-one appointment? Say, for instance, we have several clients we are seeing on one-on-one clinics with the, say, hypertensive disease in pregnancy. So if you had, say, pooled those patients who consent, will this then substitute their one-on-one appointments, if those who consent, or is it a supplement? Otherwise, thanks so much, John.
Now, John, could you please mention the watermark situation where there are those Aboriginal ladies that are pregnant and go through this? Thank you for that.
Thank you. Yeah, Dr. John, these are good questions. Obviously, in this short time, I couldn't explain in great detail some of this stuff. But when you bring your women in for the group education, the distinction is that a shared medical appointment is not just group education, and it's not a one-on-one consultation. It is a doctor-led, mostly. It can be nurse-led, but the important thing is that for us in Australia is that this is still the patient will leave thinking they've still had a one-on-one consultation with you, the doctor, even though you might then hand to the nurse to provide some education on nutrition. You are the leader still in this. It's not a nurse-led event, not a nurse-led thing. And so that's the important distinction in Australia. Otherwise, in Australia, if we just did this would be called group education, and this is okay too, but it's not a shared medical appointment. It lacks that authority that has the main provider, in this case a doctor, sort of leading it, if you like. And I forgot the second question. I'm sorry.
Does it replace the one-on-one consult? So what? Does
it replace the one-on-one? Well, the idea would be, yes, is that you would design this. So if someone comes in with a breast lump, yes, you need a one-on-one consultation or the likes. But if you've got 10 patients coming in who are all overweight, or 10 patients coming in who all have medication issues with their diabetes, this is a good opportunity to put them in a group and say, okay, rather than one-on-one, 10 minutes and you don't understand me, let's get in a group of 10 or 15 and we can all have one-on-one still, but you're all going to listen to my responses and you're all going to have a different question to ask, and together we will learn and support each other. This is when it makes a huge difference.
The other thing I will add is that in a private practice setting, you would still bill these patients as one-on-one because they will be like sequential consults. So that in that case, that is how some have done to actually make it financially viable. You could have, say, 10 clients, 10 patients, and they are billed as individuals because each one of them is consulted sequentially.
And this is important. In Australia, the way our healthcare system works, there is, for public health and primary healthcare, what's called Medicare does look after this to some degree. But there are rules in the way in which the doctor engages with the patient for them to be able to make a claim. And this is what Isaac is talking about. So in this method, we ensure that the doctors can claim each patient. That's if there's 10 patients in the room, they can claim for 10 consultations. And this makes it financially viable. But there's a technique, there's a way. I'm not so sure in Nairobi, or in Kenya, how this works, whether there's a similar scenario, but it sounds, Isaac, like you're saying there is.
Good morning, John. Thank you for the excellent presentation. Allow me, Chair, to mention one question. My name is Philip Cheptinga from Moi Teaching and Referral Hospital, Eldoret. I'm a nephrologist.
Yeah, welcome, Dr.
Yes, I just wanted to inform the members that, yes, indeed, at Moi Teaching and Referral Hospital, nephrology department, we found ourselves in doing the same, particularly on patients who are on dialysis. We have a hall where all the patients on dialysis, they do their dialysis process. You see, dialysis has not picked up well in our country. There's still a lot of fear. And doing this group training of patients, it alleviates fear, particularly the new patients who have just come. When they see the rest of the members, they get the confidence that they will be alive the next day after the session. Most also with kidney transplantation, because we do a few transplants, maybe 4 per month. And it's very difficult to convince somebody it's a life-saving process unless they see the other patients who have been transplanted. So our transplant clinics has both the pre-transplant patients who are working on the pre-transplant and those who have been transplanted. And this has really picked up. So I'm happy that, John, you have shared with us really what we have been doing. And to me, it's a success story at Moi Teaching and Referral Hospital. In terms of attendance, adherence, it's been quite good. Almost 95% attendance to our clinic, both for dialysis, the clinics, as well as for the transplant clinics. So I really appreciate this. And I think I want to encourage our colleagues, this is the future, because if you look at whereby you talk about the privacy of the patient and so forth, there are unanswered questions which they're not able to tell you that they have a lot of fear. But when they see, they learn from each other, they really get encouraged and they realize the adherence is really improved. The outcomes are good. And 5 years post-transplant care is a 98%, while the 10 years is around 92% comparable to the rest of the world. And we have around 15 years also doing well. Thank you very much.
Excellent.
Thank you, Philip. And I should say you've brought up a very good point. Many of you are probably already doing something similar already. It's just maybe it hasn't had the name or the process around it. And if any of you are working in remote villages or remote areas, you'll probably find your First Nations communities are already doing circles, yarning circles anyway, as in my country they do. And it's kind of just an extension of what already exists. Yeah.
Thank you. John, you will remember years ago, about 20 years ago, the Australian federal government funded what was called chronic disease self-management. Around 2005, I remember we used to have these group sessions, and we used to rent, hire premises that we could accommodate up to 20 people, and we could get people to sit down together, diabetics and people with chronic renal conditions, and as well as cardiovascular problems. We sit them around and everyone discusses how they are managing their conditions, from medications to what they ate, even while they traveled, how they managed to keep, their medication supplied and all that. It was amazing to see that the patients actually have answers to a lot of those issues. So somebody knows that, the other one doesn't know. And so I could sit there and I've had a nurse, 3 of us, and a social worker, 3 of us could just sit and have a hand with these people once or twice a month. Now, I didn't know that this was going to develop into what it has become now. And so it is really exciting news to actually see that there is a considerable uptake of this process that is useful for managing chronic conditions. I really appreciate the talk today. Thank you.
It's fine, Isaac. Interesting, in the United Kingdom, after COVID, they now have a 8 million person waiting list to see a GP because of the backlog of COVID and the loss of staff and all the illness. And the whole of the national health system in the UK is now going to depend on shared medical appointments as a way of trying to manage this backlog of 8 million patients who need to see a GP. That's a phenomenal number, yes? 8 million people who can't see a GP. So they're going to rely on shared medical appointments as one of these mechanisms to help move that waiting list along.
All right, we'll allow a few more comments. Perhaps we'll be winding down now. Anyone else with a comment or question, you are welcome. And John, Philip, thanks a lot for the comments that you posted. I'm sure they're what we're taking down and taking note of. Gives quite a good history on of shared medical appointments and how they come along. Thanks a lot for that input.
And Isaac, if people are interested and if there's more interest, I'd be very happy to run a short training program so people can get into more detail. We can do this online. Just pick a time and maybe allow for 2 hours to sort of really get the detail on how. The most important part of this is training the facilitator, not the doctor. Doctors just do what you do, but the facilitator is the one who's got to sort of manage the process. So that's the most important person to be trained in this.
Thank you. Nefo, do you have a comment to make before we finish? Nefo, are you with us? All right. You may have dropped out. So I would like us on behalf of